I would, when I think of system thinking, I think of stepping back from like my local ecosystem and thinking about the people, the processes, the policies as it impacts a whole institution. So I think it's important to speak systemically, primarily because when you don't, then projects that are well-meaning, well-intentioned don't work. They don't have the impact that they could have. They also have the potential of causing other issues, other complications in other areas. One example that comes to mind is our approach to hospital-acquired infection, particularly CLABSI prevention. And for a while, we struggled in getting our CLABSI numbers because we were really fixated in the local care of the central line. And then we started thinking about other things that impact our infection ratio for CLABSI. So the way we culture patients, our culture intensity, our diagnostic intensity, our antimicrobial stewardship. That's when we started moving the needle in CLABSI numbers, when we actually moved away from being line focused and we started thinking about the continuum of care for the whole line. So in this particular example, we had a little bit of hiccup when we started thinking about diagnostic intensity. So we started putting some restrictions that at that time made sense to us when it came to hospital-acquired infection. In doing so, we impacted other work that was being done when it came to sepsis bundle compliance. I think bringing diversity into your team. So do you have folks that can speak on how work is being done across multiple areas of your institution, multiple teams, multiple units, having structures in place in which you can share best practices, or maybe even just visibility on projects so that, hey, I noticed that you're working on sepsis and culturing timely is important for sepsis. We're working on hospital-acquired infection. Overculturing is one of our key drivers. Maybe we should talk about how these could impact each other. So I do think standard work is important. I think standard work helps you manage processes, improve processes, set expectations. But I also think that we're so complex that we have to have some room for variability, innovation. So I do think there are some patients that perhaps, some units, in my example, in critical care, we could have standard work about the way we mobilize patients, but the way you mobilize patients in the CVICU with lines that are keeping the patient literally alive, and these are high bore lines that need to be managed differently, that standard work needs to be a little more nuanced. So yes, we do need standard work. I am a big proponent of standard work, but we also need to make sure that we have room for variability and manage that variability as well. So when I think of standard work, I think, what are the key elements? What is the basic denominator of this work that needs to happen across all levels, all care areas? And we all agree the right patient, the right site, the right procedure. That's the verification that needs to happen. But that in the clinic may only happen with proceduralists and a patient. In the inpatient space, you may have a bedside nurse that may join you to help you verify the consent and the patient. But the interventional platform, you may have a team, but now you have other risks that need to be assessed, the fire risk, the allergies, or you need to verify procedural antibiotics for the right patient. So the intensity, the complexity of the standard work might be more complex, but there is a certain element that is the same across all levels. And I think that is what we are really good with standard work, making sure that those standard elements are verified and happens in all different areas, care areas of the institution. So observe the work, ask questions, be curious, and use the right language when you ask questions, because I think people ultimately, when you're being observed, they have their spidey senses go up. They're going to feel a little bit on the awkwardness of being observed and whether they're doing the right work. But if you approach your question with a sense of humility and a sense of really curiosity, or rather humble inquiry, this is a good book. If you address your questions with a humble inquiry, you're more likely to get a response that is true to what the work is represented, and one that probably can help you and inform your improvement work more. So as a leader, one of the first things I want to make sure is that if I am imposing change into my group or into my faculty or the ecosystem that I'm trying to change, did I bring them in sufficiently enough so that they feel change is not being imposed on them, but they're actually collaboratively participating in the change? So, and that might be a little bit more upstream before the change or whatever go live date to your project is. So did I communicate? You really should never err in over communicating. So did I bring all the right stakeholders, the people who are going to be impacted by the change, to have a voice in the change before the change happened to them? Because I think the psychology of the human is that if I had a voice before this happened to me, then I'm more likely to embrace the change. So that's one thing I think about. And then I look around and I figure out, did I check in with my innovators or people who embrace change? Did I check in with them? Did I manage the schedule so that those people are likely to be on when this change is coming on and they can help disseminate the practice that I'm trying to change? Did I observe the change? Did I iterate on the change? Did I make room for folks to give feedback on how the change has impacted their work? I think that may be my method. I don't know if I have a method, but I think those are the things that I think about. Did I communicate? Did I engage the right people? And did I bring some finesse on how the change was implemented? Did I lean into my innovators, my go-getters to help me disseminate the change? And did I make room for that feedback to be escalated and communicated when the change went live? I think the way I start my day when I'm on service in the ICU, actually there's some standard work here for both days. Strong cup of coffee, strong rest. So you need that to get going. I think the clinical day starts with kind of a sense of like triaging in your mind, like what are the top things that I really need to give my attention to? Who's the sickest? Who needs my attention at bedside? Similarly, like who is the team that I'm working with today? What are the team members that are going to need extra support versus team members that I trust to work almost independently? So there's a little bit of triaging in the clinical day that looks, well, maybe not that much different than the day when I'm leading, right? So some of my team members might work more independently. Some may need a little bit more support or presence. But there's an immediacy in the clinical work that you just have to be responsive to, right? If a patient is deteriorating and they need you at bedside, you have to be available at bedside and you have to be able to support that team. That immediacy is a little different when I'm leading a team and I'm doing administrative work or leadership work. And then what's importantly is that you understand and you kind of accept that things are going to be dynamic. Critical illness is dynamic. And then the patient who looked okay at 8 a.m. may actually look very differently at 10 a.m. So then you empower your team to escalate concerns as the day goes on, and you make sure that they know, the resident knows that if there's a concern, they escalate to the fellow knows that there's a concern, they escalate to the attending. If I have not responded back, within 2-5 minutes and the concern is really severe, are you aware of who else is in the unit to escalate to? Who are the other faculty that are present? So I always check in with my team so that they know that triaging escalation pathways, because things are dynamic. Yes, actually, we do have our own mini huddles, and we also have a huddle with the unit. Sometimes the unit may have their own huddle, and we actually join that huddle, and we hear about not just quality initiatives, but here's the number of beds that are available in this unit. Here is some of the concerns about bed availability, the number of transfers coming in, the number of discharges going out. It's helpful sometimes for us to hear that. So I always encourage my team to join the nursing huddle. If I encounter hesitancy in participating in huddles, the first thing I do is I do validate that concern. Maybe the huddle experience for that provider is one that has not added value to their day or their readiness for the day. And then bring them into the conversation. Show them a huddle that is effective, a huddle that actually is informative and empowers that provider to start the day with the key information to improve, the key information to lead, the key information to transform the area.